going to talk about more complex cases involving other joint than the basal joint. We're going to begin with Dr. Shamas. I think he's going to be the person who's going to do the talk. I cannot see him. All right. And he will talk about combined treatment of wrist and the basal joint in the same procedure, I think. We don't have him.
Do you see me?
Yes. Good morning, Mr. Shamas.
Well, good morning, everybody, and thank you so much for your invitation. It was a very great meeting and very informative. So I try to expose our approach about the combined treatment of wrist and trapeziometacarpal joint arthritis. This type of combined arthritis is infrequent, and very few references exist in the literature about the combined treatment of trapeziometacarpal osteoarthritis and wrist osteoarthritis. I don't consider STT osteoarthritis mainly. Various combination of treatment may be proposed, and we have to decide if conservation of the trapezium is better, or trapeziectomy ligamentoplasty has some indications in this combined treatment. So we are faced with patients in different situations with a combined surgery during the same operative program, or when we have secondary surgery for CMC joints osteoarthritis in a patient who had palliative surgery for wrist osteoarthritis. And the third situation is when a patient had an initial surgery for thumb basal joint osteoarthritis and wrist arthritis, which may become symptomatic in the future. So we have studied a series of 11 patients from 3 academic centers, and the interest of this study was in the 2 techniques of surgical management of the first TMC joint osteoarthritis. There was 11 patients with a mean age of 67, mainly women, and the etiology of wrist arthritis was mainly a slack wrist. The group A was treated with trapeziectomy with ligamentoplasty using the APL, 5 patients, and with in 4 patients, 4-bone or 3-bone fusion was done, and proximal row carpectomy was performed in 1 patient. In group B, where patients were treated using trapeziometacarpal joint replacement, 6 patients were included, with 4 patients with 4 or 3-bone fusion and 2 patients with proximal row carpectomy. The mean follow-up was 57 months, and 1 complication as reflex sympathetic dystrophy was observed only in group A. No ulnar translation or styloid scaphoid impingement was observed in group A, and global radiocarpal osteoarthritis in group B. No loosening of dislocation in group B, considering the first CMC joint prosthesis was observed. And as you can see, the results were comparable in terms of pain result, in terms of range of motion, and also in terms of the grip strength and Kaplan-G score. 1 example with a 67-year-old woman having a symptomatic first CMC joint and wrist with a functional range of motion and a decrease of grasp and pinch. she was treated during the same procedure with free bone fusion and first CMC joint prosthesis, for example, and the result that follow up. This combined treatment, the indications of this combined treatment are infrequent, but the combined pathologies have considerable importance, and wrist palliative surgery has two options. One is trapeziectomy with in this series conservation of the distal poles of the scaphoid with capitate fusion, and one with conservation of the trapezium with scaphoid excision, either for proximal row carpectomy or for free bone fusion. The results are comparable, but we observe a shorter rehabilitation time for combined treatment using prosthesis than trapeziectomy. And also we observe no reflex sympathetic dystrophy in this short series. We performed, since this study, more than 15 cases of combined treatment. Some example, this 72-year-old woman with a low functional demand and symptomatic wrist and first CMC joint. As you can see, she had Z deformity and mid-carpal joint osteoarthritis, including capitolinated and STT joint. She had, in this low functional demand women, a trapeziectomy with wrist selective denervation in the same outpatient procedure with satisfactory results in terms of pain evolution and strength measurement. And another patient with, she is 16 years old with symptomatic wrist due to non-union and of partial wrist fusion and the symptomatic first CMC joint osteoarthritis. There is a severe bone loss of the carpus, and we decided, due to the very limited range of motion, total wrist fusion without any graft, and during the same procedure, first CMC joint procedure, with a very satisfactory result in terms of pain, function, and strength. And the last patient is 73 years old. He had a proximal row carpectomy in 94 with, and his wrist remains asymptomatic. So he was referred for symptomatic first CMC joint osteoarthritis, and we performed the first CMC joint, total joint replacement due to the integrity of the trapezium. I thank you very much, and I am at your disposal for any question.
Mr. Chamas, thank you very much for your experience on those challenging and more complex cases. I think we're going to keep the from Mr. Aubert department, I think. 2 minutes, up to you. I don't know, you have...
Hearing me?
Yes, we can hear you. Go ahead.
Dear colleagues, I will tell you about the results of radioclinical evaluations of trapeziometacarpal prosthesis in the treatment of peritrapezial osteoarthritis. And the result roses and STT osteoarthritis association is classic and known for a long time. The risk factors for STT are known and superimposed on those for result roses. Some authors also evoke a traumatic etiology. For others, the presence of isolated STT involvement is pathognomonic of chondrocalcinosis. The clinic for STT is not very specific. Pain in the base of thumb, volar and extension pain versus resistance may be found in case of symptomatic STT. There is no consensus for the management of this peritrapezius involvement. As in all forms of osteoarthritis, the first-line treatment is primarily medical, including immobilization and cortisone infiltration. If medical treatment fails, surgery may be proposed. In our experience, it is the trapeziometacarpal joint that is responsible for the most significant discomfort. So, the management of peritrapezial osteoarthritis begins with the management of rhizarthrosis, with an arthroplasty by a trapeziometacarpal prosthesis. This is a prospective Belgian study with placement of the Carimedical Stutch double mobility prosthesis, and a French retrospective study with placement of the Evolutis Isis retentive prosthesis. And we note that for the two series, the characteristics of the population studied are comparable with patients in their 70s. The results of evaluated clinical endpoints, such as pain, mobility, and strength, were broadly comparable. For the two series, a marked improvement was observed in the clinical criteria evaluated. And regarding the radiological assessment, there is no complications over time, no dislocation or any signs of loosening. These results join those of another French series from Besançon, presented at the FESH Congress in 2018, in which we evaluated 107 Isis prostheses. We evaluated in subgroups the patients presenting or not from the preoperative stage, a peritrapezial osteoarthritis. We didn't note any significant difference between the two groups. There were no more dislocation or loosening in the group with peritrapezial osteoarthritis than in the group without peritrapezial osteoarthritis. It is not always easy to determine which joint is responsible for the most felt pain. The preoperative X-ray looking for STT joint changes is not very sensitive, around 50%. So a sequential echo or radio-guided infiltration in the two joints will possibly allow to define the one that suffers the most. You can then choose to treat STT, rhizarthrosis, or both. In our experience, after performing these sequential infiltrations at 2 months intervals, 9 times out of 10, rhizarthrosis was the cause and was relieved by the infiltrations. There are several surgical treatments for peritrapezial osteoarthritis, but not consensus. Trapeziectomy, associated or not with ligamentoplasty or interposition. It is logical to treat the two pathologies at the same time, but this could increase the risk of conflict between metacarpal and scaphoid or trapezoid. Burger or pyrocarbon implants, treating the two pathologies, but also could increase the risk of dislocation of the implant. And you can make a surgery for rhizarthrosis, like interposition pyrocarbon, chondrocostal graft, or prosthesis. It's a logical finding because rhizarthrosis is responsible for the pain in 9 times out of 10, but the risks are related to implants. To conclude, these radioclinical evaluations are in agreement with literature and allow us to answer these questions. Is trapeziometacarpal prosthesis a solution to peritrapezium osteoarthritis? And for the answer is yes. And is the trapeziometacarpal prosthesis contraindicated in the case of peritrapezial osteoarthritis? First, the response is no. Thank you.
Thank you very much. You bring us a solution for one of our questions when we are facing a basal joint arthritis. I hope it's a good one. We're going to move to the next speaker. He will face the problem another way, and he's not agree with you because he's going to operate on them and put 2 prostheses, 2 implants. So now Mr. Couturier going to bring us his experience on 2 implants in the same procedure, I think.
Yes, exactly. I think you can hear me. Thank you for everyone, especially Pascal, to propose me to share this smart experience. It's a small group of patients, and I will try to explain you why I wanted to share and to resolve this problem of the double arthritis around the trapezium, because we all know that we all have some patients who can have this arthritis around the trapezium and pain at the both sides. And sometimes it's difficult to understand where exactly is the pain of the peritrapezium arthritis. Usually it's clinically simple, sometimes it's not. But what can we do when the patient have the both sides painful, when they move the wrist, when they move the thumb? That's why I wanted to find a solution. Of course, I am one of the conceptors of ISIS prostheses. Well, that's why I have a conflict of interest. Even if today I rather use the touch prosthesis, but it's the same very stable prosthesis, and I have good results of all the prostheses I've performed now with those 2 prostheses. And that we haven't to prove the efficiency of this prosthesis, and I was very satisfied with that one. But sometimes I had patients after this CMC replacement with pain still remaining in the wrist and in the daily use. That's why I understood that we can use this pyrocardon implant like Philippe explained me and showed me previously. And personally, I have not performed so big group of replacement as he performed, but I have about 20 cases with a very good results of isolated STT joint with this pyrocardon implant. That's why I thought that we can mix the arthroplasties and perform this double implantation in the same surgical time. For the surgical procedure, you will see the YouTubes that have been performed by Philippe, but it's very simple with a polymer approach if you take care of the soft tissues, of course, and the capsule. There is a key point that you will understand later in my slides, but Philippe asked to do a resection of the horn of the trapezium to put the pyrocardon. But if you do that, and if you have a small trapezium, you can have break a slight fracture of the trapezium during the procedure. So that's why usually I prefer doing a short resection of the distal pole of the scaphoid. And I do a dorsal approach like I have done for the CMC replacement. Usually after TMC replacement, I ask the patient to use the hand very quickly. After 2, 3, 5 days, they can use daily their hand with a splint to protect in more heavy things. But if you put a pyrocardon, you need to immobilize the patient for a little bit longer time. So that's why I propose them to use the splint 3 weeks, but to every day remove the splint to do self-mobilization to try to avoid the stiffness of the CMC. Usually they have physiotherapy after this time. So it's not a series, of course, it's a small group, but it's funny to share the and to mix the results. The mean age was 73 and the follow-up is after three years. The results are very good on pain for most of patients. The quick dash is not for me, a good assessment for the peritrapezial arthritis, because patients sometimes have pain somewhere else, on the wrist, on the elbow, or on the shoulder. So you will see that the quick dash is not very good for all the patients, but it doesn't mind. They are satisfied because of the pain. Of course, with the procedure, I improved the first web opening and the radial deviation, but it's logical because of the fixation of the scaphoid with the arthritis. So all the patients were satisfied with no complications to date, no revision, no dislocation at the STT, and no trapezium collapses to date. But you will see some bone remodeling. This is one of the cases, the youngest, with a very good result on pain, and of course not a good result on the quick dash, as I told you, but she is satisfied. This is the other one coming here with 35 months of follow-up, with also good results on the pain, but not on the quick dash. The third one, you can see the same story. It's a male, but in this case, the quick dash is very, very good, with no pain today. And it's the same thing with these patients, with a very good on pain and quick dash, probably because of those two patients are younger than the others, and probably that they have no other problems than the peritrapezium arthritis. And this is another one, the oldest one, with the worst result, I think, in this group. But she's satisfied even if the pain is not completely resolved. And I don't know why she has pain, because as you can see, I'm sorry, I'm coming back, there is no other arthritis on the end. I don't understand these not so good results. And this is the last one coming. No, yes, no, it's here. With a good result on pain. You can see that in this case, I use a cemented prosthesis. It's very rare in my practice. Usually I avoid the cement, but in this case, I cutted the horns of the trapezium, as Philippe said, and the trapezium was so small that I was afraid to break it. That's why I didn't impact or screw the ISIS prosthesis, but to put a cemented one, it's not a good idea. What about the bone remodeling? Some cases, and especially in this one, shown that the bones are changing around the pyrocardon, but it doesn't matter because in this case, I have 3 cases with a bone remodeling during the follow-up, but with no change of about the results. And what about this traveling implant? In some cases, with functional X-rays, I can see sometime at the different period of the follow-up that the pyrocardon seems to move inside the STT joint. To date, in this small group, there is no differences for the results during the time, but it's interesting to see that, and perhaps to take care of the future. So usually the literature shown that in this combined arthritis, some interposition has been proposed by different procedure we saw previously. And it's for me, Philippe, who changed the mind of the hand surgeon with this proposal of this burger arthroplasty. That's why I wanted to try to use the CMC replacement with a ball and socket prosthesis rather than the pyrocardon, because it's my practice. And today I know that yes, we can do it, and of course, yes, I do it. Thank you.
Thank you very much for this elegant solution for a very complex situation. We're going to come back to you for question in the end of this session. We're going to move to the next speaker, Dr. Touzi. She's going to bring you the experience of our group, our department, on the use of P2 implant on the peritrapezial arthritis. It's up to you.
Hello, everyone. First off, thank you to the team for giving me the opportunity to present today. So as Nader said, I will be talking about our center's long-term experience with the PI2 implant. So although there are no published algorithms concerning TMJ arthritis treatment based on the different stage, surgeons must pay particular attention to patients with advanced stages because there is an increased risk of concomitant scaphotrapezial trapezoidal arthritis. Indeed, up to 62% may actually have pantrapezial arthritis, and its correct diagnosis can be challenging because of sign and symptom overlaps, as well as the lack of correlation with the Eden-Littler stage, as we've seen in presentations earlier this morning. Though conservative treatment options are the same for both TMJ and pantrapezial arthritis, certain surgical treatments for TMJ are entirely unsuitable for pantrapezial arthritis simply because there is a second and sometimes a third joint to take into consideration. And if left untreated, these two joints can be a source of persistent pain. So removing the trapezium has long since been associated with loss of thumb strength because of first metacarpal proximal migration. And so replacing the trapezium became an interesting option. Pyrocarbon had, in this situation, proved to be an excellent option when compared to other synthetic materials that are shown to have adverse reactions. So our study evaluates the long-term results after using the PI2 pyrocarbon interposition implant. 94 arthroplasties were performed in 87 patients, of which only 20 patients were available for follow-up at an average of 7.2 years after surgery. 2 of these procedures were revision procedures following initial trapeziectomy, while the remaining 21 procedures were primary procedures. Post-operative follow-up included bilateral measurements of strength, the Kaplan-G score, the quick dash score, evaluation of pain using a VAS, and both preoperative and post-operative x-rays were studied for the M1 over M2 ratio, as well as implant dislocation. Key points of surgical procedure are the delicate single block trapeziectomy, partial trapezoidectomy, and here ligamentoplasty was performed in 10 out of 23 joints. For results of the study, we had no statistically significant difference between the operated and the contralateral hand when it comes to the objective outcomes. We should note that 1 patient was excluded because he was hemiplegic, and 3 other patients were excluded because surgery had been performed bilaterally. When we compare this, when we look at the post-operative quick dash score, we have an average score of 8.7 and a VAS that was at 0.7. So patients were relatively happy with the results. However, there was no correlation between the quick dash score and the objective outcomes that we saw on our previous slide. When we look at the x-rays, we note that the M1 over M2 ratio was 0.7 preoperatively and 0.68 postoperatively. And this difference was not statistically significant. In our patients, we had 84% who had a normal preoperative ratio, and while 52% had a normal postoperative ratio. And this 52% included both trapeziectomy revision patients. So these patients had seen their ratio elongated. For the dislocation, we had 6 dislocated implants at follow-up, 2 of which had ligamentoplasty performed, but the population is too small to be able to have a statistically significant difference at this level. So for as long as trapeziectomy was the gold standard for TMJ arthritis, any scaphotrapezial arthritis had been treated at the same time, whether or not it had been diagnosed beforehand. However, the proximal migration of the first metacarpal was said to cause thumb weakness. Though TMJ replacement succeeds in maintaining the thumb column height, it uses the proximal part of the trapezium for bone anchoring, making this technique inadequate for STT arthritis because, as previous studies have shown, this can patients remain symptomatic even after surgery. So replacing the trapezium with the PI2 would address both of these problems without causing any adverse reactions as we've seen with other synthetic materials, and it requires few surgical revisions since subluxated implants generally have had acceptable clinical results. Therefore, subluxation is not synonym for implant dysfunction. And our study even suggests that this could equally apply to dislocated implants, because of the 6 patients we had that had dislocations, none of them had really any different clinical results compared to the patients that had their implant that was in place. So since our study and previous studies did not find any correlation between thumb height and strength, there does not really seem to be any added benefit to using the PI2 implant in this indication for pantrapezial arthritis. In addition, a learning curve may actually explain why some surgeons experience more negative results than others. So we primarily suggest using the PI2 implant as a salvage procedure for failed TMJ replacement and failed partial trapeziectomy. It's also the only solution if for failed total trapeziectomy, and it can also be used as a potential solution for patients with MCP hyperextension. Indeed, this implant does not require any bone or ligament fixation because it remains mobile inside the trapezial fossa, allowing it to keep up with the complex thumb range of motion while adapting itself to the patient's specific anatomy. So the determining factor of its stability is really the integrity of the surrounding tissues, and these tissues are potentially reinforced by scar tissues that result from the initial surgery. In conclusion, the PI2 is successful in maintaining and restoring the thumb column height after trapeziectomy, as well as providing positive results in the long term. However, this study and many studies suggest that the thumb column height does not really correlate to strength. The PI2 does not seem to provide any long-term benefits for patients with primary pantrapezial arthritis, but it may be an interesting salvage technique for failed primary procedures, such as total trapeziectomy. So we recognize that our study has a small population because unfortunately many patients were unavailable for follow-up. We recognize the necessity for larger studies concentrating on these revision procedures. Thank you.
Thank you, Dr. Todzi. We're going to keep the question for the end of this session as usual, and we're going to move to another solution similar for the same problem using the rec joint. Dr. Bogart, she's also reporting our experience with this device. I don't know if when you use the rec joint, it's not an implant because it's going to disappear and get dissolved. Dr. Bogart, it's up to you.
Thank you very much. I will speak about the rec joint. So in our center, when TMC or SCT arthritis are major, or in case of loss of trapezium height, a trapeziectomy is proposed to the symptomatic patient. The main complication with the trapeziectomy is the shortening of the thumb column by proximal migration of the first metacarpal bone. This situation leads to a weakening of thumb opposition and to painful scapho-metacarpal conflict. To avoid this, the adjunction of ligamentous suspension or several interpositions are proposed. The rec joint is a porous bioresorbable temporary spacer. It facilitates the development of a dense fibrous pseudoarthrosis in the articular space. We designed a study focused on symptomatic patients with major TMC arthritis associated with major STT arthritis or loss of trapezium height. We found 20 patients with an average age of 67 years, and the follow-up had to be at least 1 year. It's a retrospective study in which we perform a subjective and a clinical evaluation with strength and mobilities measure. We also perform a radiological evaluation with several radiographic measures and grade. 100% of our patients have declared a pain diminution and an 82% a functional gain. 95% will choose the operation again. Regarding the strength evaluation, our patients keep an acceptable level of strength comparable to the other hand. Concerning the mobilities evaluation, the only difference concerned the postoperative MCP flexion and the carpal disc. In comparison to the contralateral side, the surgery causes an average degrees of 19 degrees in flexion and a median reduction in the carpal disc of 1, but without clinical major repercussion. There is no difference between the pre and the post-operative Kaplan-G score. Only 3 of our patients had a minimal bone erosion. We saw a proximal migration and a height reduction of the thumb column, but without clinical consequences. We also saw an amelioration in terms of first thumb column, front thumb phalanx subluxation. With our trapezoid relationship gradation for collapses, we noted an overall metacarpal migration grade deterioration. Our first aim was to evaluate whether the region degradation causes a periprothesis or osteolysis. This complication was reported in 3 studies by Maitila and 1 from Kennedy, where it could be associated with foreign body reaction or revision surgery. These results contrast with previous animal experimental studies, which showed a good biocompatibility, and with studies focused on rheumatism patients, where there is no evidence of significant osteolysis or adverse tissue reaction. This also contrasts with our results. We have few osteolysis without showing clinical impact or foreign body reaction. The first explanation could be determined by the type of trapeziectomy. A partial excision or arthroplasty surgery revision can lead to an incorrect distribution, incorrect forces distribution on the implant, and which could cause premature wear of the implant. And the loose bone fragment could trigger an adverse tissue reaction. Thus, by performing a complete primary trapeziectomy, we could ensure better constraint distribution. The other possible explanations are a tight insertion of the implant with possible loss of porous quality, may be associated with a foreign body reaction, and interposition space preservation by destruction clear wire may block any recurl of the thumb and decrease the force on the implant and the adverse tissue reaction. Our secondary aim was to evaluate whether the reagent may restore and maintain the thumb anatomy, strength, and mobility. We observed a decrease of the thumb column height, but not associated with any clinical functional consequences. When using our trapezoid relationship gradation for collapses, we compare our migration result to another study focused on simple trapeziectomy. We notice a tendency for greater degradation of the grade when a simple trapeziectomy is performed. Regarding the different strength analysis, our patients keep an acceptable level of strength comparable to their other hand, even if in the case of the operation on the dominant side, a slight decrease in strength is assumed given the absence of difference with the non-dominant side. In terms of mobility, in comparison to the contralateral hand, the surgery causes an average decrease of 19° inflection and a median reduction in the Kaplan-G score of 1, but without clinical major impact. There are several evident limitations in our study: lack of preoperative data, the retrospective design, a possible bilateral osteoarthritis, and our small population. To conclude, in the literature, there is no significant evidence-based superiority amongst surgical treatment for TMCG arthritis. Concerning the region, we show that this implant is safe and biologically inert. We did not highlight any significant complication, adverse tissue reaction, bone erosion, pain, nor functional disorder. On the contrary, our patient showed a subjective improvement both in terms of pain and functional results at minimum of a 1-year follow-up. We have demonstrated that this technique is a reliable and safe option for the treatment of TMC arthritis. Thank you.
Thank you, Svetlana, for your talk. We are just on time to move to the last speaker of this session, Professor Ilse de Greve from Prellenberg. She's going to bring us another question. Is there still a place for a trapeziectomy? Is up to you.
Thank you.
I don't know.
Thank you. Do you hear me? Okay. I'm not from Prellenberg, I'm from Leuven. And I just want to correct this because we have moved since a little over a year now. So we're all in Leuven, Gasthuisberg, and we're very happy here, although we miss the ease of Pellenberg. So thank you, Anne, for asking me this question. Is there still a place for trapeziectomy? I seem to not be able to move the slides. I cannot move the slides. Are you going to do it for me then? Or... So the simple answer could be yes, and then we could conclude, but I'll use my 8 minutes. If we compare trapeziectomy with a nice and modern implant, it's a bit like comparing an old and a new car, and we all have the tendency to really give attention to the new car. But is the trapeziectomy an old car? That's the question. Next slide. If we look at history, it is true that the simple excision of the trapezium is an older car. But if we look at all the more novel techniques, trapeziectomy with ligament interposition, as described by Burton and Pellegrini, versus the true implants, whether it was silicone or the more recent de la Caffinière, which is the ball and socket that we still use today, then you could debate a little more about what is old and what is new. And to this point, we are 40 years later, we still do not have a concise answer to the question. So maybe the question is not so easy to respond to. Next slide, please. If we look at the joint biomechanics, every joint has its own anatomy. Please press. What we are doing today in the modern technology, not next slide, but press please. We are replacing the saddle joint by the ball in socket joint. So we're doing something really strange to recreate normal motion in the basal joint of the thumb. Next slide. And still we are not satisfied. So still the result is not 100% what we would like. We have heard so much today on this subject. And we know that although most of the time the ball and socket technique of implants is preferred, we still are not there what we want to be yet. Materials are being improved, polyethylene is being made stronger, and now we are even evolving towards a bipolar reconstruction. So the last of this implant is not set yet. Next. So when we look at outcomes, the only thing that we know and that we do all agree on is that when the thumb is shorter, that we end up with loss of strength. And that's what we all want to avoid. We want to make the patient better, but we want to preserve the length of the thumb. Next slide. And when we look at all outcomes, they are quite comparable. These are all older studies, but the next studies are quite comparable. The overall success rates, next slide, are between 85, 90%, even a little higher if you have a short-term follow-up. And we also know that most of the time, if pain is lower, function is better, grip and key pinch strength are better. That is what we know, independent of the technique. Next slide. What we also know is that when we use an implant, it will wear out, and a lot of times it will loosen. We do not know what this does in trapeziectomy. There's nothing implanted, there's nothing to get loose, but a lot of times we use tendons and we do not know what happens with that in the long term. Next slide. So when we look at outcome, when the question is there still place for trapeziectomy? The trapeziectomy still has a place, but most surgeons prefer to use the LTI, to put the tendon in the same time to preserve this length. Next slide. And the most important thing, and I hope we will do that in Belgium soon with the help of Joris Durings of his initiative, we have to follow the implants in the long term as is done in the Norwegian arthroplasty to see what the survival rates are, because this impacts the patient's future and the society's future. Next slide. And will the technical evolution of the prosthesis, the implant, but also the technique be the answer to increase survival and increase results? I'm very eager to see the results of these novelties, next slide, that are introduced also with a lot of work with of Joris Durings, with answers to reaming, positioning, centralization, stabilization. So the implants may improve. Next slide. But if we compare at this moment, long term, we have to be honest, there is no true difference. Next slide. If we compare outcome, the outcome is reasonably high and the satisfaction is reasonably high for all techniques. About 85 to 90% will have an almost a normal hand function depending on the general condition. Next slide. But the complications are different, and that's what we need to do today. We have to inform our patients so that he or she can make his choice. We look at feasibility, but we have to inform on outcome and possible complications, which are a little different between techniques, where we know that dislocation is preserved for the implants, loosening is as well. Shortening is more likely in LTIs and not in the implants. The imbalance risk is higher in implants, but not absent in the LTIs. Fractures are more common in implants, less in LTIs, but not, they do exist. The pain certainly initially after surgery is bigger in LTIs, and the rehabilitation is longer. The weakness and strength may be comparable. Infection risk is too. There's a lot of debate apparently on the SDT arthritis, as we have seen in the previous lectures, but there is no consensus or true hard material available in literature. And we do know that if you have a scapholinated fast collapse due to the SDT arthritis, that this may increase after trapeziectomy and is not influenced when you use the implant. Next slide. So what is the preference? To me, I am concerned about the SDT arthritis, and I am concerned in cases of small trapeziums for an implant. In hard labor, I would avoid any implants, and financial reasons can play a role. Certainly, as we have seen, if you already use 2 implants, it is more expensive. It also depends on the experience. If you are a very experienced surgeon in implants, you will have better results than if you don't do that a lot of times. So experience of the surgeon is also of importance. Adduction contractures, MCP arthritis can be a challenge, and in those cases, I put a level for decisions for implants a little higher. Next slide. So is there an answer? At this moment, there is no answer to what is best, but I can answer the question, which is easy. Is there still a place for trapeziectomy? Yes, most of the time with the ligament interposition. In elderly, a simple trapeziectomy might be helpful, and recovery might be easier. So last slide. Last slide. So the answer is yes, but let's stop looking for the one and only best. Let's look for the predictive parameters to find out what technique is best in what situation. And let's not be influenced by the companies for making this decision. The companies have another option if we would not use it much for the thumbs. The hips are, those small hips are also welcome in the hips of Chihuahuas and little cats. Thank you.
Thank you, Professor de Greve, for your very clear talk. So we can still do trapeziectomy. That's good. I have we're going to begin with question. I don't know if anyone have any direct question. I have a question from Dr. Lucier regarding the double implant by Monsieur Couturier. He's asking if you prefer to do both procedure in the same time, or do the first one and then come back to the second one. Did you understand my question, sir?
Yes, yes. It was my microphone. Yes. In my practice, I have performed about 500 prosthesis CMC replacement, especially with ISIS and touch prosthesis. Of course, a lot of patients have an STT arthritis, and when we perform only the CMC replacement, the STT is much better after, and sometimes they don't have any pain still in the wrist. The cases I presented are so a few cases because it was patients with an important pain on the wrist before surgery. And this is what is sometimes difficult to understand. For some patients, I propose to do the CMC replacement and tell them that in the future, if the STT is painful, we will be able to do this second prosthesis. But in many cases, it's not useful. And the cases I presented are those that where the pain were very important at the wrist before surgery, sometimes more important than the pain on the CMC joint.
Nader, are you still there?
Sorry, because I think I was lost and I'm back. Thank you for your question. I think the major question is if the STT joint is painful at the beginning. I think, in my opinion, it's easier to do the both procedures at the same time because it makes shorter and you don't have to bring back the patient to the OR and to do another operation. It's going to be more expensive. But I think it's case by case, and we don't have any experience on double implants. I don't know if other surgeons have this experience on double implants. Right. Is there any other question? I have a question from Mr. Shamas regarding when you perform a first row carpectomy and a trapeziectomy in the same procedure. What's going to happen to the thumb?
It's a main question of our work. And the series with total trapeziectomy was performed by Caroline Leclerc in Paris. And I was very interested in her procedure. And she performed during this surgery a total trapeziectomy and a fusion of the distal pole of the scaphoid with capitate, and a small radial styloidectomy. So I was very surprised by this procedure. And Caroline said that, and she showed us that there was no subsidence of the first ray and no ulnar translation. So in my hand, it's I consider a very complex procedure, and with a long procedure in the operating room. So I have no experience of this procedure, and now our first choice is first CMC joint prosthesis in combination with palliative surgery of the wrist.
Excellent. We have a question from Nadine Olvutz. She's making a remark that trapeziectomy is difficult to treat, and many cases can be avoided by using an implant. I think that's obvious. That's why in our department we learned by Pascal Ledoux to perform total joint implant. And I think you're right, Ilse, that experience and technical accuracy is the most important thing to do. And I think it's not too difficult to teach to younger surgeons how to do it. If you do it properly, you have less problem than trapeziectomy in our hand. and to correct a failed trapeziectomy, it can be challenging. And when those patients are painful, it's not easy to correct that. I don't know your opinion on failed trapeziectomy.
Well, I think that the correction of any failed surgery is always a challenge, and it will lower your success rates in second surgery. It is independent whether that was a prosthesis or a trapeziectomy. There are techniques to do the suspension in my practice, because I'm experienced with the trapeziectomy at this moment more than the prosthesis. That you can do a successful suspension, and you have a success rate of about 80% in secondary surgery. On the other hand, I do also a lot of revisions after failed prosthesis, and it can be challenging as well, because it's a fixed stem, and I don't have to tell all that, I guess. And I think it's, well, I'm a little concerned about the idea that, well, if it fails, we can do something else. No one's happy if you'd have to do something else. So we have to be a little more careful with that idea, because we are surgeons and we like surgery, but the patient doesn't like it. So that's my idea on this. Everyone's looking so seriously now.
Right. Is there any other question? Wow. And are you hearing me? Because I lost the image, but
Okay.
do you have the voice? Yeah, all right.
We have the voice, but video is lost.
Yeah, all right. You have the voice? Excellent. If there's no more question. Il n'y a pas de voix.
No more question.
Okay. You don't have the image. All right. Ah. J'ai déjà fait. All right. Something happening with the image. I don't have the video, so it's okay. If there is any other question, we can move to the next session. Yeah, we can move. We're going to move across Atlantic Ocean and join Jean-Paul Brutus in Montreal. He's going to talk about Walant anesthesia to perform total joint replacement. Jean-Paul, are you here?
I am here. Can you hear me?
I can hear you. You don't have the image of me. I don't know how come, but we don't have.
Okay, maybe if I start this video. I'm unable to start the video for some reason. Okay. So good morning and good afternoon to everyone. It's good to be back in Belgium, even if it's only virtual. Great talks this morning. I woke up very early to listen to you, and I'm happy I did it. So this talk will not be about surgical technique. It's going to be about a novel technique of anesthesia that I think allows to have better results when we do joint replacements. And now I'm trying to change my slides, but I cannot. Oh, okay. So Walant is a wide awake local anesthesia without a tourniquet. As you know, it's become extremely popular. And it was made even more so by Donald Walant, who's a fellow Canadian. He's in New Brunswick here in Canada. And Walant is pretty much a extravascular Beers block. Plastic surgeons are very familiar with tumescent technique. And Walant is nothing but tumescent supplied to the upper extremity. It allows now to perform a lot of procedures on the upper extremity, but also elsewhere in the body. You can perform fixation of fractures of the radius, the ulna, the clavicle, the patella, and the ankle under local anesthesia. Trapeziectomy, joint replacements can all be done under Walant now, and this is what I'm going to talk about. I think there are great benefits to performing a joint replacement under local anesthesia. Among those are the fact that the patient does not need to be NPO, so you're avoiding nausea, you're avoiding dizziness for the patient. There is no longer a need for blood work or preoperative tests like EKGs. Obviously, there's a reduction in costs because of that, but also there's increased revenues and profitability for both the surgeon or the center. The patient will not be complaining of tourniquet pain, as normally they would with a Beers block. And I think that's one of the big ones. The patient is able to demonstrate, I mean, you are able to demonstrate to the patient what type of active range of motion you're able to get on the operating table. You're able to film that also to show the patient later and to guide your hand therapist when it comes to the rehabilitation. And I also believe that it provides the patient with a much better patient experience. Now, there also are technical benefits to using Walant for joint replacement. I believe it allows you to perform a better selection of the implant components and to identify problems of instability or impingement very early, that I mean immediately on the operating table. For example, this video shows you the dislocation that occurred during the procedure. And this can be corrected immediately. I'm trying to move on to the next slide. Okay, here. The medication I will provide to the patient is basically anxiolysis and pain medicine prior to the performing of the anesthesia. I start with marking the anatomy of the patient, because once you're going to blow a mix of lidocaine and saline everywhere, you're going to lose the landmarks. So it's important to mark the metacarpal bone and the trapezium prior to the injection. So I'm going to use a mix of lidocaine and saline. I like to select a 27 gauge needle to minimize the discomfort to the patient. You can also use a 25 gauge if you want. I have a hard time controlling my slides for some reason. Okay, so how much I'm going to use depends. The dilution of the solution is going to depend on how much I'm going to use. If I plan on using less than 50 cc's of fluid, then I will use pre-mixed 1% lidocaine with 100,000 epinephrine. You can add bicarb if you like to buffer the pH of the solution to decrease discomfort. I don't do it because I don't think it makes much of a difference, but I know that Don Lalonde will disagree with me. If I want to use more fluid, then I will increase the dilution, as the slide just showed you. So then I really want to minimize the discomfort of the anesthesia. So I'm going to talk to the patient, explain what I'm going to do before I do it. I will pinch the skin to create some sensory noise to minimize the pain. And when I insert the needle, I make sure I insert the needle perpendicular to the skin into the subcutaneous fat. I will stabilize the syringe to make sure there's no pain associated with the wobbling of the syringe. I like to use a vibration device to create sensory noise. And this really makes the injection completely painless. So I will start by injecting the first maybe half a cc or 1 cc, and then pause to make sure that needle pain disappears. And then after that, I will inject very slowly the first 10 cc's over a very slow period of time. And as you can see, it really goes everywhere and it too messes the area. Then I will pay attention to reinsert the needle into the skin that's already numb and inject from proximal to distal, blowing the local anesthetic slowly ahead of the needle. And as Don Lalonde likes to say, you know, he uses the blow slow before you go phrase to remind him to inject very slow. So the key is to inject very, very, very slowly. You should almost not see the plunger move in your syringe. And if you do that, there's literally no pain. So I use about 45 cc's of the mix I described. I would put 10 cc on the dorsal aspect of the trapezium, 10 cc on the dorsal aspect of the first metacarpal, then 10 cc on each side of the metacarpal. And as you can see, it goes everywhere. Then you really have to be patient. You wait about 30 minutes. You really need to observe the skin blanching due to vasoconstriction. And you know that you'll have a very, very nice bloodless field. You may warn your patient that in maybe 1/3 of the cases, they may experience some type of jitters, as if they had been drinking a little bit too much coffee. This is what I call the adrenaline rush. So it's important to be patient so you have proper anesthesia. And this is what the thumb looks like after it's been injected. You can see the skin is white everywhere. The thumb, the first web, and the forearm. The BioPro implant and the Maya implants are the implants that I use. There are only two. These two are available in Canada. I won't describe the surgical technique because it's pretty standard and you are experts. But I want to show you this. You can see that there's absolutely no pain during drilling. You can see there's a bloodless field. So it's very comfortable for both the patient and the surgeon. And you can enjoy some good music while you're doing this, and so can the patient. And this shows you that the patient is tapping along to the music, so they're having a good experience. So it's actually all about the patient experience. And I think that is one of the most important benefits. So now, this video just showed that I was able to identify a subluxation.
Jusqu'en bas, jusqu'avec le petit doigt. Maintenant, vous ouvrez bien la main. Ouvrez bien la main, voilà. Touchez l'index, le majeur, le quatrième doigt, le petit doigt, et maintenant dans le creux de la main.
So very important, I think, is to identify a intraoperative problem like instability or subluxation. This is a post-operative result 12 days post. I'm very confident because I've seen this joint move intraoperatively, so this will guide me with post-operative therapy. Patient experience is very important. This is what a patient had to say, and this patient is actually a surgeon himself. He was able to actively participate. He felt more in control, felt that anxiety was much less than it would have been otherwise, and really felt that he was a partner in the procedure, which is, I think, very important. So I believe that the joint replacement can now be made less invasive with Walant and provide a much superior patient experience while allowing the surgeon to identify problems as they occur during the surgery, and therefore preventing dislocations and instability. Thank you very much.
Thank you, Jean-Paul. It's really interesting because you can test your implants on the table. It's like in flexor tendon surgery. I think it's a major plus to be sure that your tendon is gliding properly. In your case, you can see how the patient is using his thumb, and you don't have any immediate problem. I don't know if there's any question from the audience. We don't have any, I don't know how to call it, audience or not. And
so, thank you, Jean-Paul. Thank you to get up so early this morning for us. So I think that we can close the session and to say goodbye to all the participants. I would like to thank again, Pascal Ledoux for the participation, for the organization of this Congress. Thank you very much, Pascal, and thank you very much for all the speakers, especially the French speaker. There are lots of French speakers with us. Thank you for all the participants, and for the Congress will be online in a few weeks, perhaps in 2 or 3 weeks. I don't know exactly. It will be online, and you can enjoy it later if you want to see it again. So thank you very much to all. I close the Congress. I don't know if Pascal, you want to say a little word? I'm not sure that Pascal is still there. So Pascal, can you answer? Never mind. Thank you very much to all, and see you at the next Congress. I would like just a last thing to remember that we would like to organize a national registration in Belgium of the prosthesis. It will be our next work for the team of the board of the regional group, with especially Joris Durings. So probably that in a few months, next year, you will have to organize the registration of each prosthesis to check our long-term results, which is the most important to see the viability of the prosthesis. Thank you very much. Oh, Pascal, you are back.
I was always there, but I was not with the speaker.
The video was closed, sorry.
And thank you very much for this Congress. I was very honored.
Thank you, Pascal. So bye-bye to everybody. Thank you for the moderators, and thank you, Pascal. Oh, last thing, the sponsor, K-Medical, Vigo, Zyber Biomet, Depuis, Artrex, Aliamet, DGO, X-Medical, Hospital Innovation, Integra, and Smentis. They help us, sorry, for the Congress. And thank you very much to all the sponsors. Later on the next Congress. Thank you.